Hello, my name is Dr. Ashish Contractor, and today I'm joined by my good friends, Dr. Sushil Bindru, who is our Director of Pulmonology as well as Quality Initiatives in the hospital, and Dr. Rahul Pandit, who's our Chair of Critical Care Medicine and Emergency Medicine. Now, on 17th of September is World Patient Safety Day, and this is a topic which all of healthcare needs to take very seriously, and I'm happy to say that we at RFH take it very seriously too. There are certain guidelines which the international organizations have when we call them the International Patient Safety Goals. There are 6 very important ones which ideally all hospitals should follow. I know we take them very seriously, we track them on a routine basis. And what we thought we'll do today to enlighten you is just mention each of those 6 and speak a line or two so that you also get familiar with it and you can be part of patient safety. So the first one is correct patient identification. So Dr. Rahul, why is that so important in a hospital setting?
So, Dr. Contractor, as we all know, the basis of patient care should be primum non nocere, which is do no harm. And these 6 quality initiatives, which have been now become a standard across the world, actually are a product of that whole ethos that we need to do no harm to our patients first. And the most important one is identify the patient correctly. So, if you want to actually treat somebody, that person should be identified uniformly across the hospital so that there is absolutely no confusion. And when I'm saying across the hospital, either they are walking through the emergency department or they are walking to the outpatient department, right up to their discharge process, there has to be a clear identification of the patient. And many times we start losing that identity by labeling the patient as a room number or a bed number, which becomes a big problem. I'll give you a classic example. There are few surnames in our country which are very common. Shah, Mehta, Pandit. They might be a very common Gupta. They might be very common surname. It's not unusual to have 2 or 3 common surname patients at the same time in a particular ICU or in a particular floor where they are admitted. And if we start labeling them differently by room numbers, we are going to create more confusion. So the best way to identify a person is full name and date of birth. And according to these 2 things, the patient gets a identity number in the inpatient number if they are admitted in the hospital. If they are the outpatient, they get an outpatient number. And when we identify them on a written label, all these 3 details come into the picture, and that's the right way of identifying a patient. And calling a patient, talking to a patient should be with their full name so that we actually do not have any confusion, especially when you're chasing reports in the morning and trying to relay the reports, when you're trying to inform a procedure or you're trying to communicate to a family member. You need to clearly identify and say that I'm talking for Mr. So and so, and that name should be first name as well as the last name so that there is no confusion. Because quite often, relatives also get confused about the room numbers and bed numbers, and it is not uncommon to have a miscommunication there. So, hence, identification of the patient with these 3 things is the first most important step of patient safety.
Yeah, I think that's important. I remember every time I come for a blood test, it'll always make you wear a band in the last two. Is your name so and so? Is your date of birth so and so? So I think that's important, and not to use room numbers, which at some point we've all been guilty of, but that's a habit that we need to overcome. So the second one, which sort of comes from the first, Dr. Sushil, is effective communication. Now, while that's a, if I may say so, a common sense kind of a thing, there must be that there should be effective communication. What does it really mean in a sort of a medical sense?
So what Rahul said, the first thing, most important thing is when the patient comes to the hospital is that you make some guidelines or some of your protocol that you identify the correct patient. The second important thing is that once we come to a new place, you are lost. Where you have to go, what you have to do, whom you have to meet. So every hospital should have a proper protocols or SOPs for effective communication with the patient right from the patient enters to the hospital, whether he's an OP patient or he comes for any investigations or he is admitted to the hospital, and then till the time he goes back, leaves the hospital. Now, the advantages of that is that every patient or their relatives, I always tell everyone, they don't come to visit us, they come out of their misery. So we have to make them comfortable, and I personally feel the best form or the best way to make a patient comfortable is how you communicate with them. You have to give them a friendly hand, you have to give them a friendly sight, a friendly talk. So communication is not only about getting the patient in and making them comfortable. It's also about what the doctors, what the nurses, what the other healthcare staff, what they talk to them and how they talk to them. So, like if the patient is in pain, a simple gesture of just touching the patient, although with permission, and then talking to them, it will be better. It gives a relief to them. It's all emotional. That you have to emotionally connect with the patient, and every communication has to be as per the state or condition of the patient and the patient relatives. One more thing is, whenever we are breaking a bad news, again that way also the communication is important. How you are communicating with them, how you are breaking the news. I think Rahul will be in a better position to tell, because most of the bad news is, we also in the OPD sometimes. I had a patient right now, so I'll give you a simple example. Today's, so he came with some pleural effusion, and cough since past one month. So X-ray was done outside, having a pleural effusion. He was tapped. So most of the people, he has a history of weight loss, and also most of the people think that is tuberculosis. But luckily, one good doctor had sent him to me, and he's one of the ADAs, one of the majors to diagnose pleural effusion, to TB in pleural effusion. So it is negative. Now I told the family, it might be a cancer because he's an old patient and all, but how you talk to them, how you, it is just a provisional thing. It makes a lot of difference to the patients and the patient's relatives. So effective communication at all levels is very important for patient care and patient safety in the hospital.
Can I just
Of
add to that?
course.
So, Dr. Bindru highlighted about the communication with the patient and every member of the hospital. There is also an effective communication between the teams of the hospital, and there are communication tools also. One of the simple way of communication tool is the ISBAR communication, identify, situation, background, and there is a mnemonic for that. So I believe that every communication should be done with a closed loop. Whether you use a ISBAR as a tool or whether you don't use ISBAR but you follow the same principles, within the team the communication should be closed. A simple example of that, I might ask my nurse to give an injection, I will write it down. The closed loop will be, sister tells me I've given this injection, and then she comes and notes down that I've given the injection. That's a closed loop communication. So between the teams also, communication, a closed loop communication is important, because only then the patient safety is ensured.
You also have that read back policy, right? If you're to tell them
So
something
that's
over
for
the
verbal orders.
verbal, over the phone,
Yeah.
they will repeat it back to you, because so many things also kind of sound similar.
And second person also does it. So there are two people who need to read it back to us.
Okay.
So verbal orders are only in a case of an emergency, a super emergency, where it needs to be done now for the patient and the doctor may not be there at that
Otherwise, you
point.
always put in the
Otherwise, it
system or
has
you
to be
write
a
it
written
down.
order only.
Okay, that's great. So I like the, when you introduced, you said that do no harm is the first principle and of medicine. And the third and fourth safety goals, and I will combine them, which are safe medication usage and safe surgery. Now, one normally takes for granted that if you're going to go to a hospital, of course, it's going to be safe usage and of course, it's going to be safe surgery. But the reality is errors happen. So, could you stress a little bit on, what do we really mean by safe medicine and surgery?
Again, these two are the corner pillars of safety for a patient in the hospital. Now, when we talk about safe medication, so the first step starts with medication reconciliation. And I think that needs to happen within the first 1 hour of the patient coming to a hospital as an inpatient. And if not as an inpatient, if they are going as an outpatient, the doctor who is treating or seeing the patient needs to do that while they are in the outpatient department.
What does
Now,
that
what
mean?
is reconciliation? Reconciliation means I might be on 4 medications for my diabetes, blood pressure, thyroid, whatever. Okay. And I might come with a completely different problem or a related problem. So the doctor needs to, when the doctor is going to decide to treat me or order my investigations or do a clinical examination, it will be in the context of what tablets I am taking. so that they are able to appropriately diagnose as well, because some conditions may be associated with the tablet. For example, if I'm on a fluid tablet, my low sodium may be associated with a fluid tablet. The second most important thing about reconciliation is that when I am giving a drug as a prescription to this patient, I need to know what medicines the patient is on, so that when I am giving a drug, whether there are any drug-drug interactions, whether I need to change the timings of the drug, whether there is any toxicity or potentiation of any action of these drugs, that needs to come into the picture as well. And third thing may be that I may have to actually stop some offending drugs which may be causing a problem. So medication reconciliation is the first step of safety medicine. And then the second step is when I start prescribing the patient a new medicine. It may be a simple paracetamol tablet for a fever, or it may be a very complex onco drug or a chemo drug or a immunotherapy drug or something. All of that needs to again follow the same principle. Identify the patient, communicate to the patient what drug you are giving, why is it being given, what are the problems, what are the complications. Make sure that they understand it, document it in the notes, talk to your team, do a closed loop communication with the team. The team, when the medication is prescribed, the pharmacy needs to again identify that it's for the right patient and the right dose. There has to be a back check which happens in our hospital all the time. Every drug prescribed in the ICU is checked by a clinical pharmacist. It is checked for appropriateness of the dose, it is checked for appropriateness of the drug, it is checked for appropriateness of the patient, and also for any drug-drug interactions or side effects. Then the drug gets dispensed. So again, right patient, has it been dispensed to the right patient or not? So there are too many touch points, and then the nurse has to appropriately dilute it or mix it or administer it, whether it's oral, IV, or it has to be basically given per rectal. There are different routes of administration. That completes a safe medication process. Safe medication process is just not the responsibility of doctor does not end by prescribing. It actually starts much before you actually even prescribe a drug. So it's a very long process. I always say that in the olden times, I had heard that when a pilot would start a jumbo jet 747, they had to do 700 odd touch points to make sure that the jumbo jet was fit to fly. Now most of it is probably done electronically, and they just get alarms that they're okay. But previously it was all manual. For a hospital, everything is still manual. You have automation in prescriptions, you have automation in dispensing, but until last point when the doctor or the nurse actually sees and administers, that manual effect will never go away. So our touch points are akin to 700, 800 odd touch points that the patient would have in 24 hours, what a pilot does for a jumbo jet maybe 30 years ago. That's the surgery, that's the medical part. And the
So
second part was,
I'll just add
you can
on to
add,
what
yeah.
Rahul. So I think there are 6 points of medicine management in the hospital. As Rahul said, the first thing is the prescription. After the reconciliation, once you are giving a new medicine or continuing the increasing the dose or decreasing the dose, the first thing is the prescription when the doctor writes. Second thing is a transcription. What the resident doctor sends it to the pharmacy. Now, why are we so? There can be a gap there, but what Rahul rightly said, he said about the ICU, I'm saying it is being done throughout the hospital. Validation is done. That I think that's the most important thing, that it is validated by a person who is actually then giving the medicine. It is done across the hospital. Every medicine which has been transcribed is validated by the clinical pharmacist. Then the fourth point is then they dispense the drug. Fifth point is that once the drug is seen, then fifth point is what Rahul said is the human touch, is the administration of the drug. And the sixth most important thing is that monitoring the effect of the drug. Now, this completes a closed loop right from the prescription to the monitoring of the drug. And this, we follow this meticulously
Scrupulously.
in every nook and corner of the hospital. And we are very good in preventing the all the medication adverse effects.
And hopefully, this is all done by humans and not by AI, right?
Yes.
No, so
So-
look, prescription, some automation has to be there,
Yeah,
but as you said, there has to be human intervention.
Absolutely.
And validation, there's something called a look-alike sound
Yes.
alike. So drugs sound alike, some ampules or some tablets look alike.
Correct.
So you need to be very sure that if it's a look-alike, sound-alike tablet, then you need to talk about another thing which is important, which actually takes away this look-alike, sound-alike problem a lot, is you start prescribing by the generic name, not the brand name. and that will take away the look-alike, sound-alike problem to a different level altogether. It will go down completely. It will not be a daily problem for us.
And we are doing it
And
now.
we are doing it now completely.
Started doing it now.
Surgery, safe surgery.
Safe surgery. So safe surgery, again, same principle. First, need for the surgery, uh, whether the surgery needs to be the way, what we need to talk to the patient is that what is the best patient-centric surgical problem that we can actually solve for them. Then actual ethos of this safe surgery is right patient, right site, right time, right date. Those are the principles of a safe surgery which come across. Plus, the surgery just does not translate to surgery, it also translates to anesthesia care as well. And same thing for anesthesia also, where drug administration, again, right patient, right time, allergies, all of those things come into the picture. So there is a significant overlap between, and quite right for you to combine the two together, because there is a significant overlap. But here, the primary reason for a safe surgical practice is to make sure that we have the right patient and we have the right site. You must have heard in newspapers people talking about right hand surgery, left hand surgery, those kind of things. In fact, a cardinal rule which is followed in our hospital is site marking. So even before the patient goes to the operation theater, the surgical team has to come and do a site mark.
Take like a marker and
It's a marker pen. If it's a right kidney which has to be operated, the marker has to be on the right side.
And I know they have a read back even in the
Yeah,
anesthesia
so I was coming
team.
to that. When the patient goes into the operation pre-anesthetic room, there is a stand down time for patient safety check, and the nurse reads about the patient's name. Patient's name is confirmed. If the patient is, say, a sedated patient from ICU, it's a relative who is talked, that is this the right patient. The label is checked. So there is a three-way confirmation: verbal, label, and what is being written with the patient's relative. And the surgeon introduces themselves. The anesthesia team introduces themselves. Right site is discussed. The nature of the operation is discussed, and then the patient is taken up for the anesthesia and surgery. So this is a very important step: right patient for the surgery.
Amazing. Dr. Sushil, this is a topic I know close to your heart, which is infection prevention. That's the fifth patient safety goal. Um, we all know that infection prevention is important, but maybe you can give us some insight into the degree and the depth to which this is tracked and how often is it tracked.
So, as Rahul said, first principle of medicine is no malfeasance. That means do not harm the patient. The rule should be that a patient, whether he comes infected or he comes uninfected, we should not give him an infection. That should be embedded in every healthcare worker's mind and soul, because a new infection causes a financial stress, financial burden to the patient relatives, length of stay increases, then we need to use newer resources for his length of stay, other patients keep on waiting, and ultimately, because these infections are hospital acquired, the chances of getting them out of this infection are less rather than people who come infected from a community, because the resistance to the antibiotics and various drugs is less in case of community acquired infections rather than the hospital acquired infections. So we at RFH have got a dedicated team of around which includes the nurses, the clinicians, the ID specialists, the ICU team, and the microbiologists who meticulously follow each and every quality indicator for infection control. So we have, for example, various bundles which are being followed. Like in the ICU, we have got VAP bundle for the prevention of ventricular associated infections. Then we have got the COTI bundle for the urinary catheter infection. Then we have got SSIs. So, for example, he said that Dr. Raul said that up to the surgery, then we have a post-op care. And the most important complication what the patient can get is a surgical site infection. So we track them and we prevent them. The fourth one is that you have a CLBSI, like you have got lines in the which can be the arterial lines, the central lines, the peripheral lines. You can have infections related to them. So these are some of the bundles which are being meticulously followed. The people are being trained The training is done almost, it includes the nurse training, it includes the doctor training, it includes the HK support staff training, which is being done every um, twice a week, and following up. Then we have got these, we have made these as quality indicators. We have got something which is called MDRO, which are the multi-drug resistant organisms. So everything is followed meticulously. We do screen patients who come from outside hospitals to find out whether they have got. Then we do isolate them. We have got strict isolation practices. We have got almost around how many percent of beds in the ICUs you have got where we can do
So
isolate
we
the
have
patient?
all single beds. So all patients can be isolated from contact precautions, and we've got around say 8 beds where we can actually do respiratory
Isolation.
isolation as well.
And in the floors, we have got almost every floor has got around 2 to 4 beds where we have got proper isolation room with the anti room where we can change the pressure from neutral to positive to negative depending on the patient size. So we follow meticulously. Then we have got we we are always below the international or the national benchmarks for infection control.
Below in a good way.
Below in a good way.
Yes.
So what we have done to be more stringent, to be not in the comfort zone, we have formed our own internal benchmarks, and we always try to be below those benchmarks. So that is, we are there, we are always below our these benchmarks, which is in a good sense that we don't encourage and don't try to give infection to the patients from the hospital.
And most important, we learned in COVID, hand washing.
Yes, I think
Yes.
COVID, post-COVID, hand
The
washing,
number one.
hygiene is the most
Masking.
important thing. Masking is the
Yeah.
most important thing. And if we are all guilty of, including patients, doctors, nurses, all healthcare professionals,
No,
sometimes
I know we
taking it
track them
lightly.
a lot. We get emails saying so and so,
Yeah.
so and so, so and so. And hand washing is also not just one. They're like
Yeah.
moments of hand
Moments.
washing. So
Yes,
I think
yes.
we're doing a good job of following up. But the last one is fall prevention. Now, again, while that sounds obvious, I think we know that in the hospital we get patients with some of them are very debilitated, um, in the ICU, in the rooms, in our rehab
In your
area.
rehab, you can just
I
The
think you would be able to tell
neurological
that for
patients,
Yeah.
and
rehab
How
patients
do you
better.
do them? Like they
no, so
come,
we have a
they got
system in the hospital where we put them into high risk for falls, and literally every patient that enters into our hospital, we have a fall risk assessment as one of the parts that we fill on the patient's chart. And when they're identified as high risk, they wear a yellow band, and then certain precautions are going to be there. The truth of the matter is that all of these things, while we all do our best, it's never zero. That's just the reality. And you know that when we sit in meetings and when we see 0, 0, 0, sometimes we're almost suspicious that is this real data, because we want to try to go towards zero. And I think it's the responsibility of the whole healthcare system, literally every person, starting from security to housekeeping to patient to their relatives to, of course, doctors, nurses, and all of them, to really make sure that safety is important. Just to reiterate, 6 main goals, international patient safety goals: correct patient ID, effective communication, safe medicine usage, safe surgical practices, infection prevention, and fall prevention. And I think this year our theme is more about pediatric and child safety.
this time. This theme is very good because somehow we always feel that more of the force or whatever you say is given on the adult patient
Importance is
care
given to the adult
importance.
patient care.
So this time, I think WHO comes with all these good theme. I think this is a very good theme, that it is the safe care for the newborn as well as the pediatric patient. So
that's
it's
very
everything. So yeah, good.
Well, I think I agree there. That's even more vulnerable population because UNH can't complain. So you need to be very sure
point.
that there is no harm done to them.
Yeah.
And I believe the theme is right on the spot, and it is a very important area to be looked at.
So thank you, both of you. I
Thank
think
you.
you
Thank you
gave
so much.
very succinct and very nice examples and information. And I hope that all of you listening got a good insight into patient safety. And let's all work together to make it even better, even safer for everyone concerned. Thanks so much for
Thank you
joining
so
us.
much.
Thank you.
Thank you.